you so much for all those who have chosen to spend the next 45 minutes with us. Our schedule will be as follows. Dr. Alejandro Lopez will be our first speaker, followed by Jason Silverstein. After the presentations, we'll have about 10 minutes for questions and answers. During the presentation, please submit any questions you may have to the Q&A folder found on the bottom of the webinar. We're very fortunate to hear from our first speaker, Dr. Alejandro Lopez. Dr. Lopez is a pediatric cardiologist at Children's National Hospital in Washington, D.C. He also serves as the medical director of telemedicine and has extensive hands-on experience with the growing technology involving telehealth and telemedicine. Dr. Lopez, I'll turn the time over to you.
Thank you. Thank you to Jason and Jessica and the organizing committee for allowing me this opportunity to share with you our experience with the telemedicine response for Children's National to this pandemic. I can say with confidence that Children's National has implemented so far a successful telemedicine response to COVID-19. I'm trying to demonstrate my points to you. I believe we allowed for increased protection for children, families, and staff. Also, we virtualized care or the overall hospital operations, conducted massive training for our staff, and the outpatient and inpatient settings. And also, very importantly, we helped to mitigate the huge financial impact that this pandemic has had in our institution, as well as, you know, it has happened in others all over the US and the world. This is our telemedicine program, and it's focused on it's shadowing the hospital organization, focused on outpatient and inpatient. Primary care, ambulatory specialties for both out and inpatient, school and ED, the ICUs, and we had a dedicated part just to procure additional funding for our growth needs in terms of grants, including a COVID-19 one. To understand how we did what we did, you have to take a little step back and look backwards, understand where you are, and then you can lay out a road to the future. Children's National has a significant long history of telemedicine leadership in the US and internationally. Our program was traditionally focused on store and forward, so to speak, operations, meaning mainly remote reading of imaging studies, for example, echocardiography and EEGs. When we came over a few years ago, 2.5 years ago, we wanted to just go other way. And looking back, it looks like we were preparing for the pandemic. We just didn't know that we were doing that. We had a vision to become a best in class children's center virtual hospital, to be able to leverage our clinical expertise with technology and then keep children at home and provide care wherever they are and whenever they need it. That sounds simple, but that is very complicated to deliver. There was a long road from this vision to where we were. That's the second part. You need to know where you are. And you know, sometimes looking at yourself at the mirror, sometimes it's difficult because being objective is a difficult task. But then we did this diagnosis and we knew that the program structure, business model, the technology that we had available and the staffing at our disposal were insufficient to support the future growth that was needed for this vision. So we devoted the last 2.5 years to work on a centralized telemedicine work hub to have a good internal financial oversight and billing process. Also deciding what would be the optimal telemedicine technology and the metrics for success. We were working very hard on this, and outside Children's National, licensing and reimbursement issues was the scenery that provided a lot of opposition, a lot of hurdles to this. And this has been traditionally the case. On a separate front, general IT issues, we had also problems that prevented us from just conducting massive telemedicine operations. We had limitations in wireless capability, bandwidth, a dedicated VPN for telemedicine operations, and IT support. So this is just a very brief summary of the road we walked. At the beginning of 2018, we presented our strategic business proposal to the hospital leadership. And the middle of that year, we were able to advance this vision to the Leadership Council. And then that was the point in which we got the hospital leadership to buy a little bit into this vision and to dream a little bit with us about this virtual hospital. Then we organized regular meetings just to advance our organization and our processes. And at the same time, on a parallel way and a separate issue, this is separate from telemedicine, the Bear Institute conducted a significant revamping of our IT capabilities. That was a significant improvement. At the beginning of 2019, we started up formal operations of our CICU command center and dedicated a good part of that year to the process, to the decision to change telemedicine platform and the transition to the new one. This is the CICU command center as it stands now. And I believe this is, it is where I'm standing here. And it is a place where clinical expertise, virtual technologies, and AI coalesce to add a second layer of safety over patient care. We believe this is the way of the future in many hospital and clinical operations. And I'm showing you here our monthly telemedicine volumes for the last 2 years, or a little bit more than that, just right before the pandemic. And the first half of 2019, we dedicated to the analysis of the different technological offerings, and the last half to the transition to the platforms that we chose, mainly was Zoom. And we were, as you saw, going a little bit up on telemedicine consultations volume, and then we got COVID-19. With COVID-19, that completely, as you know, turned the whole hospital upside down, and hospitals all over the US and the world and our own lives. So that needed a forceful response to respond to the pandemic. At the beginning of March this year, there was this, the Coronavirus Preparedness and Response Supplemental Appropriations Act. With this law, there were tools that were provided to waivers, mainly Medicare waivers, and licensing waivers that allow for rapid deployment of massive telemedicine operations. And we moved on that, and less than a week later, we had a telemedicine program response plan in order. And then we worked hard on communicating this to our own staff, including 2 town halls in March and April, and working with the division, the clinical division chiefs along this plan. We had this deployment plan, protecting our staff as much as we protected, the children. That was one of the main goals. And we started virtual triaging at the patient home with a chatbot, with an AI chatbot that was placed in the hospital webpage, and it worked fine. And that's the first triaging spot. And then we also work on additional virtual triaging in the ED to decrease exposure to the ED staff that is significantly at risk to this virus. And then work on outpatient with the primary care specialties and the inpatient with specialties also, and the NICUs and the ICUs. Then we needed to really train a lot of people, but we were ready because we had already established an onboarding process and we knew what worked. We had a model that worked. So this way we were able to increase, a lot the number of clinical providers with the whole completed the onboarding process for telemedicine, from 82 to a little bit more than 900 in 1 month, and a little bit more than 1,000 in April. So we were lock and loaded, and that allowed us to achieve a spectacular increase in the telemedicine consultations. And you can see this is the pre-pandemic. You see my mouse. This is February 2020, and we were providing 77 consultations a month. From there to 14,000, 16,000, that's a huge increase, and that protected our patients and allowed us to provide valuable service to our patients. This is another way to present these clinical consultations in the outpatient setting. In blue, the traditional consultations, in red, the telemedicine consultations. And you can see the Children's National Response officially started at the end of March with a rapid increase in the telemedicine consultation volume. At the same time, the in-presence consults plummeted. But overall, just comparing to the historical average, we were able to achieve comparable numbers, a little bit more so, with the combined telemedicine and in-presence operations. On the inpatient care, we also conducted a virtualization of care to allow for improved social distancing. This is our CICU hybrid rounds with an in-touch device, in which the clinical pharmacist and the dietitian and some fellows or some attendings could participate in the rounds, and decreasing then the number of in-presence staff. There is a way to improve on this front, but that is you move those in a good, in the good right direction. Also, we were able to provide support for families via iPads, secure iPads, so they could communicate with their children in case, or staff in case they could not come into the hospital. And also allowed for telemedicine consultation, inpatient consultation for specialties in the COVID units and non-critical care sites and the ED. So the pandemic is a new disease, as you know, and there's a lot of things that we needed to, to understand. So we Ricardo Munoz, our leader, telemedicine leader, and he had this idea of having a weekly webinar, and we have conducted 14 weekly webinars in the international setting with 72 institutions from all the continents participating at one time or another, with the main focus to share early experience from epicenters in China, Europe, the US, and then later on in Latin America, focusing on organization, response, and challenges, and new treatments. And this has been very successful. And also, just last but not least, getting funds to sustain the effort is very important. I believe the virtualization of care was financially sound, and I show you here that the collection rate for telemedicine consultations during the pandemic has been even better than the traditional collection rates that we have. On another front, the telemedicine program was able, under Shireen Atabaki's leadership, to procure an awarded grant for telemedicine gadgets, hardware, software, devices to deliver care for our patients. And this is the team, just a great, a special shout out to Shireen Atabaki, Rachel Seligman, Ariel McDade, and Ashraf Haraste, that they were really the ones training a lot of clinical champions for the whole divisions to allow for the increase in outpatient consultations. And also the rest of the team, was working quietly on the back to support these results. In summary, Children's National has implemented a successful telemedicine response to the pandemic so far. But virtualization of care is probably here to stay, I believe, in some parts at least. And there remain significant challenges ahead in the post-pandemic world, especially in the human factor. We want to do things as we are programmed to do. Financial, laws and regulation, and technologies. And I want to end this with this quote from Dwight Eisenhower. He said once that, remembering his experience in World War, that in preparing for battle, I have always found that plans are useless, but planning is indispensable. We're just planning for the unknown. We need to be ready. We don't know when the challenge is gonna, knock on our doors, but if it can be tomorrow, or 1 year, 10 years, but if it comes to us and we're not ready, we may be overwhelmed. And the converse is the same for opportunities. Opportunities present sometimes once in a life, and we need to be ready. Thank you.
Thank you so much, Dr. Lopez. That was a really great presentation. I got very jealous when I saw that command center. That was very, very impressive. I'm gonna share my screen here. And we're gonna, I apologize that I did not show this in the beginning when I introduced Dr. Lopez. That was a great picture, so I want to make sure we got that on there.
Looks better than me.
But thank you so much. I'm sure people will be very eager to ask some questions following Jason's presentation. So we'll move on to Jason Silverstein. Jason is Director of Innovation and Transformation at White Plains Hospital in New York, as well as Director of Operations for East Post Road Ventures. His background in finance, business, and technology, or with his background, he leads the hospital's telemedicine and virtual health strategies. Thank you so much, everybody, for being here. We're looking forward to questions and answers afterwards, but we'll turn over the time to Jason at this point.
Thanks, Cameron. Can you confirm you can see my screen and hear me as well?
Yes and yes.
Great. Good morning, everybody. Thanks for that introduction. As a brief agenda for today, I'll talk a little bit about White Plains Hospital and our venture fund and innovation incubator in East Post Road Ventures. Talk about telemedicine here at White Plains Hospital, both pre-COVID and since COVID arrived here in Westchester County. Talk about some of the initiatives we have in flight, and then talk about what's next as it relates to virtual health and telemedicine. White Plains Hospital is a 292-bed community hospital in White Plains, New York. During COVID, we were forced to expand to more than 400 beds. Established in 2019, is a wholly owned subsidiary, a incubation incubator, a incubation accelerator, and venture fund. What that team does is provides access to capital, collaboration opportunities, and commercialization planning for early stage companies. One of our portfolio companies, his name is Metasprout. Metasprout was a key element in launching our virtual health and telemedicine program as quickly as we were able to do it. And just a noteworthy, White Plains is part of the Montefiore Health System. As a community hospital, part of a larger parent system that provides a lot of opportunities, but also a lot of challenges in deploying technology as well. I'll start with pre-COVID. We were challenged by our leadership team to deploy virtual health. I think admittedly, really we were trying to deploy virtual health because some of our neighbors were doing it. Neighbors in NYU and New York Presbyterian, Mount Sinai. We didn't have necessarily the real strategy to support deploying virtual health, but we started to lay the groundwork of what would later become a very important backbone to the telemedicine strategy for March. Our first use case through Metasprout's platform was our cancer center genetic counselor. Patients would still come into the cancer center here at White Plains, but our counselor was located off-site, out of state. This was done based out of an organizational need, where, again, patients came in-house, providers were remote, so we could really control the environment and understand a little bit more about virtual health, not depend on patients' Wi-Fi, apps, or anything else. Next, we launched the WPH Connect app, which was our organization's first foray into app development, playing in the Apple App Store, eventually the Google Play environment as well. This was our white-labeled solution from Metasprout. We also had a program that was sponsored by the IHI Healthcare Improvement West Health Grant with our local EMS partner in Empress. We would send paramedics out to high-risk patients' homes, and we were able to connect ED physicians to these patients and the paramedics. This was done in the emergency department with a lot of support from our ED leadership, who always wants to be on the forefront of technology and always progressive in how they approach this. The need we were set out to challenge early in 2020 was to deliver virtual urgent care for our employees. As a self-insured organization, some of the challenges we had to face were around what types of providers were going to provide coverage, were we going to bill for these services or not, how and where we were going to document in what EMR, and whether or not we were going to integrate this solution into a greater technology stack. As I said before, we're part of the Montefiore Health System. We lean on Montefiore for a number of different technology needs, but pre-COVID, the lack of telehealth strategy was a little bit challenging as we are forced to play nice with our parent, but also like to move at a little bit of a different speed. So I'm happy Dr. Lopez did not use my Churchill quote. He went with a Dwight Eisenhower approach instead. So never let a good crisis go to waste. From a technology and operations perspective, COVID represented to us an opportunity to really drive innovation and technology strategy forward in a way that we never would have imagined. On March 20th, 2020, we fully launched our virtual health ecosystem, White Plains Hospital Connect. We have an app on the Apple App Store and the Android environment as well. We went about this in a non-integrated way with our EMR. Longer term, this is not ideal to be not integrated, but shorter term, we were able to scale very quickly and bring this to market more or less overnight. We put out dedicated phone numbers. We had multiple marketing and SMS campaigns, which I'll get into in a little bit. You can see kind of what the app looks and feels like right here. And as Dr. Lopez shared before, minimal volume through March. And what we see here is a pretty substantial growth. I showed you before the genetic counseling and paramedic visits only totaled 150 visits, at all time. March, over 1,000 visits, close to 10,000 in April. You can see here that in April, 51% of our outpatient operations was actually delivered virtually, as all of our outpatient practices were forced to close down. All sorts of unknowns hit the local environment. We saw massive growth in April and May. You could see that some of the growth was tapering off and continues to taper off a little bit. But over the 90-day period that started our true virtual health deployment, 23% of our outpatient visits were actually delivered virtually. Earlier this week, we actually accomplished our 25,000th virtual visit, which was a big accomplishment for this organization. And through July, we're trending about 150 to 175 visits per day. That first week in this deployment in March, we trained over 250 individual providers across a variety of subspecialties, and the patient and provider feedback we received, was pretty substantial, ranging from "this is absolutely fantastic" to maybe there's some opportunities for improvement. As our outpatient practice is closed, the organization realized that we really needed to go all in on virtual health, at least in the short term. So I have to give a shout out to our marketing team, who in just a couple of days were able to really pepper the landscape of Westchester to make sure that all of our patients and really all of the residents of Westchester County knew that White Plains Hospital had switched to virtual. We're offering virtual, and we were right here right when you need us, as our marketing team says. So about a month in, we polled some of our providers and got some great feedback. We do this monthly now, alongside hosting open forums for all of our users. I think the main takeaway here was that really patients need a little bit more help and troubleshooting, and as do some of our providers. Going on the bottom here in some of these quotes, we see that when it's good, it's great. When it's bad, it's really bad. No one notices when the solution works perfectly, but we really hear about it when there's any errors or glitches in the process. Just a comical quote from one of our physicians here: "Why is it called WPH Connect when it does not actually connect to anything?" We took that to heart, as the goal is obviously a fully integrated solution one day, but we wanted to make sure that we can connect with our patients wherever they are and make sure that our patients know that we're there when we need them, when they need us. Some of the lessons learned: for basic telehealth with just video, we found that it's mostly an operational lift and very little clinical impact. Very little clinical considerations need to go into deploying. Much bigger lift on our operations, meaning our schedulers, our office assistants, and how practices run needed to change. So it was a much bigger operational hurdle than it was clinical. But a lot of problems that we encountered actually were agnostic to the solution and the strategy that we put in place. Being forced into this put a lot of non-technical savvy users into the ecosystem. Our teams had to deal with not understanding how to use mute buttons, the wrong browser, Apple IDs that were incorrect. We were forced to have our frontline staff not only play, COVID heroes, but also Apple Genius support. which is really, you know, not a great use of everybody's time, but it was a trying time in the very beginning. From a patient's perspective, I think what we learned very early on was expectation setting is key, educating patients on what they need to know, but also understanding that virtual health, at least right out of the gate, is not really the solution for everyone. And I think longer term, from an IT perspective, what we really need to do is provide real-time technical support for those that are having trouble, some of our older patients, some patients who have other challenges with technology. You know, those types of things, as we look to continue to grow this program, will be paramount for future success. Outside of the patient-provider relationships in the ambulatory setting, we also leveraged virtual health on the same platform in our emergency department and one of our urgent cares. So you see here on the left side, we have a picture of Dr. Matt Shafaroff, who's our Chief Medical Information Officer. What we were able to do is set up a tent in our emergency room parking lot, our emergency department parking lot, in order to preserve PPE and keep some of our providers out of those front lines. We built a testing site with multiple iPad stations where providers can actually triage patients in the tent, test them without ever actually making contact with the patient. On the urgent care side, we were doing something very similar, but patients actually were not leaving their cars. To date, we've done close to 1,500 visits in our tent. In the early stages of this, we were doing hundreds a day. Now that's tapered off just a little bit. What's next? Outside of the virtual health solution that we've delivered to our patients, we're looking more internal in the hospital, and we're leveraging a partner in Ironbow. Ironbow makes interprofessional consult carts where providers and their care teams can wheel one of these carts into a patient's room and make sure that we can have the right consult and the right expert provide care. Our first use case for this will be our telestroke program, but we have a number of these carts in order as well, where if there is a major COVID wave 2 in Westchester, we could actually put some of these carts in our field hospitals in the county and state and have our care teams help out on-site care teams remotely. As we expand visit types and look towards a more integrated patient experience, we'll start here in the hospital and talk about some of the other things that we're doing here on the ground. Our leadership has really bought into this type of solution, understands that the platform has a ton of value to it. I'll speak to some of the creativity and some of our clinical leadership, breastfeeding support, MA pre-charting. These are projects that we're scoping out right now to try and leverage the same technology, but provide a better experience for really everybody in the care continuum. Virtual discharges is something we deployed last week, where as visitors are still not allowed in the hospital, we want to be able to include care partners and family members as part of the discharge process. So we're leveraging the same WPH Connect solution for that. Coming October 2020, we'll be launching a disease-specific kit program where we'll be sending patients home with all sorts of integrated devices and move towards remote patient monitoring. Also going to look at how we can redesign the outpatient office workflow, go to more touchless and something called a pre-visit visit, where maybe a medical assistant or some other office clerical person can meet with the patient prior to them coming in to minimize time in the waiting room and actually time in the doctor's office. As I close this out, some advice for some of the listeners out there to get involved. Telemedicine is definitely here to stay, as Dr. Lopez pointed out as well. I also suggest staying abreast to regulations in every area across the care continuum. Telehealth updates are happening often. Just recently, physical therapy is now completely reimbursable virtually, so we're trying to leverage the same solution for that. Embrace the new normal, and if anybody has any questions or needs telehealth advice and solutions, feel free to reach out.
Awesome. Thank you so much, Jason. I'll go back to the slide here. And then it's time for some question and answers. Yeah, really appreciate both of the speakers. Amazing data and experience that both of you were able to share. Very impressive. We have a thought-provoking question from Dr. Rafael Torres that I want to modify a little bit because I think it really is an interesting one. He asks, who benefits most from telehealth, the patient or the provider? And I think it's easy to kind of say, you know, there's elements to both, but I'm going to kind of prompt you guys to choose one. So I'll go ahead with Dr. Lopez first. Who benefits most from telehealth, the patient or the provider?
I think first and foremost should be the patient. And I'm not a patient. I have not been a patient, you know, in this pandemic, but we should focus on the patient. And if we have solutions that are great for us, but not good for the patients, then probably there is no use for those. And of course, there should be also, you know, a middle ground in which we find some solution that is, well, some good for patients and clinicians, but we have to be focused on patients. And I can envision families being grateful for not having to drive miles and miles and, you know, lose, you know, work days just to bring their kids to the consult. And sometimes just for a consult that is just, you know, a few minutes. And, you know, and now in this pandemic, even more so. That would be my assessment.
Great thoughts. How about you, Jason?
Just for conversation's sake, I'll take the opposite. I'll take the opposite angle, that the providers and the care teams also benefit a ton from telehealth and virtual health. I think we can get more providers involved in the continuum of care for an individual patient with technology. I think as a patient goes through the care settings, from outpatient to if they need to be in the emergency room or admitted, and then back into either post-acute care and back into their homes, I think the technology allows a more collaborative approach to delivering medicine. And I think that's something that you know, the organization here, and I think the industry at large, can clearly benefit from. And I think that's something that the patients don't even realize. Obviously, being able to see your doctor from your couch is super convenient, but there's a lot more that's going into it behind the scenes.
Yeah, and I think we both made an effort to go to the opposite side, because it was very easy to think that actually when this started, we were more concerned about our staff, and we still are concerned about our staff. And now we can also understand there's problems with, you know, severe disease in children too, not to the extent of adult patients, but still, that was not the original thinking.
Awesome. Thank you so much. We've got several questions rolling in here, so we're gonna do our best to address as many as we can. We only got a few more minutes left, but Candace Dawes asks, what's next in terms of delivery of telemedicine to patients in their own homes? We'll go with you, Jason, first.
Sure. So White Plains Hospital is taking the approach of what we'll call disease-specific kits, which can also be kind of more geared towards family medicine as well, where as patients come into our network, however they get here, we'd like them to leave, or at least give them the option to purchase, or we're still working on the business model for it, but leave with a number of integrated devices such as pulse ox, scales, blood pressure, thermometers, and all sorts of other scopes that we can deliver to a patient's home, and they could provide you know, data back to our care teams so patients never have to leave their homes. I think we're taking it more of a family and disease state scope more than an individual patient buying a device at Best Buy.
Great, thank you. How about you, Dr. Lopez? What's next?
I agree with Jason that, you know, there is a great disruption, big disruption in the setting, the clinical setting, in hospitals, and clinics all over the world. We need to accept that. And I think hospitals, surviving hospitals in 10 years from now, they're not going to look the same as they do now. Or maybe a little bit like they're starting to look now, but certainly not the way they looked last year. This is not going to be driven by clinicians or medical teams or health providers or even insurance. Yes, we do have an impact and say, but the consumer, and that's a term that is not comfortable for one as a physician, but you know, the great population outside healthcare, the ones receiving care, they're the ones that have already experienced a good part of it and experienced the benefit. And also, they had this epiphany probably that a lot of these in-presence consultations are not needed now, really. You can take a look at a post-op patient and I need 30 seconds of good video feed and a good additional pictures of the surgical scar and a few good questions and maybe a few gadgets, similar to the ones Jason is suggesting. And that's all I need for many of these consultations. And the disease-specific kits, yes, diabetes, chronic lung disease. We're going to the medical home and the revival of the virtual home visit. 19th century reloaded.
Great, awesome stuff. I think we're going to try to squeeze in one more here. I'm going to extend it to both as well and kind of modify here. How do we avoid major mistakes and setbacks as we're implementing all of this technology? Let's go, Jason first. Oh.
I think Dr. Lopez alluded to this before in planning and preparation. I think White Plains was fortunate enough to have a little bit of a framework built, but I think being able to fail fast and, as long as the mistakes aren't catastrophic, I think, mistakes are going to happen. And I think it's how you learn from those, push something forward, fail fast, iterate, and keep going. You learn something, even if it's just something small, from more or less every telemedicine visit. At least the first handful, each one of them were eye-opening. So I wouldn't let major setbacks really set the whole, major mistakes set you back. I think it's also a very forgiving time as well in patient care and the transformation of care delivery. So, patients expect an Amazon-esque experience maybe in other areas, but this was a very trying time for the healthcare industry, and I think people were a little bit more open-minded to some glitches and errors. So fail fast and get back on track as soon as you can.
Absolutely. Thank you, Jason. A few thoughts, Dr. Lopez, before we close?
Just going back to the human factor, I think one of the main obstacles for this, because all the financial and the regulations, that is going to respond to the public demand. And I think there's going to be overwhelming support for change. Many of the things that were thought like unsurmountable, maybe even a few months or years ago. Going back, the human factor is a problem. We are pack animals. We like to, be close and look at our faces, and we like to touch. Some, ones more than others, but we're primed for that. Genetically primed for that. And that is one, probably the resistance to change is also one primal, reflex that we are programmed to avoid the danger in the way of avoiding new things. The familiar is that something that we grasp on. We need to get used to the new things. And know which ones we really need to hold on, but change is going to be the norm, and as has been for many years now.
Great. Well, we want to applaud you both for your efforts in helping further telemedicine and telehealth. It's really, really impressive what you both have accomplished. And thank you so much for sharing this information with us. A lot of it's very thought-provoking for all of us, and we really appreciate it. Thank you so much for everybody who has been in attendance. We invite you to continue to log on to the remaining sessions, as there's a lot to come yet. So thank you so much, everybody. Thank you, Jason. Thank you, Dr. Lopez. Really appreciate it.
Thank you.